The management of refractory and super-refractory status epilepticus frequently requires the induction of burst suppression. However, the endpoints of these therapies remain ill-defined, especially when the process is complicated by the emergence of EEG patterns along the Ictal-Interictal continuum. Should I abort, or should I continue the weaning process pending more definitive seizure activity? What is the significance of the Ictal-Interictal continuum? Welcome to the Neurocritical Care Society podcast. I'm your host, Fawaz Mufti, podcasting from Westchester Medical Center and New York Medical College. Today, Sterain Shepard is joined by Alvin Das to discuss the recently published paper entitled Successful Weaning Despite Emergence of Ictal-Interictal EEG Patterns During the Weaning of Prolonged Burst Suppression Therapy for Super-Refractory Status Epilepticus. Hope you enjoyed this episode.
Hi, I am Sterain Shepard, Assistant Professor of Neurology in the section of Neurocritical Care at Rush University Medical Center in Chicago, Illinois. My guest for today's episode is Dr. Alvin Das, who is a Neurocritical Care Fellow at the Massachusetts General Hospital, Brigham and Women's Hospital, and Harvard Medical School Fellowship Training Program in Neurocritical Care in Boston, Massachusetts, and the first author of a paper recently published entitled Successful Wean Despite Emergence of Ictal-Interictal EEG Patterns During the Weaning of Prolonged Burst Suppression Therapy for Super-Refractory Status Epilepticus. Thank you, Dr. Das, for joining us on today's podcast.
Thanks for having me, Dr. Shepard.
So, status epilepticus is a condition that we frequently encounter in the neuro ICU. This paper specifically looks at a population of patients with refractory status epilepticus, that is, seizures that do not cease despite administration of benzodiazepines and anti-seizure medications, who ultimately require IV anesthetics. For those of us who are intensivists and not neurointensivists who are listening to this podcast, can you tell me the difference between refractory status epilepticus and status epilepticus?
Sure. So the definitions are a little bit unclear, but in general, we say that refractory status epilepticus is status epilepticus that has persisted after administration of a second-line AED, which could be an intravenous therapy or additional benzodiazepine. After you administer those and the status persists, we term that refractory status epilepticus. I think the distinction is important because it's important to recognize refractory status epilepticus very early on, given that it has a high mortality, probably threefold that of non-refractory status epilepticus, and about 20 to 40% of patients with status epilepticus will end up going into refractory status epilepticus. And then if the refractory status epilepticus persists despite initial measures for 24 to 48 hours, we call this super-refractory status epilepticus, which is what the paper really focuses on.
And I know that there is a lack of evidence regarding the management, especially of refractory and super-refractory status epilepticus, especially how long to continue these IV anesthetic therapies, like how long should we continue the IV propofol? Should it be, or Versed, should it be 24 or 48 hours? And especially when to stop IV anesthetic therapy. And this paper is interesting because it specifically looks at the EEG patterns that develop during the weaning of IV anesthetics, namely patterns along the so-called Ictal-Interictal continuum. Can you explain to our listeners what exactly are these patterns? What are the patterns that we can see in the weaning of IV anesthetics along the Ictal-Interictal continuum?
That's a great question. So typically, if there's status epilepticus that progresses to super-refractory status epilepticus, we often use intravenous anesthetic agents, propofol, midazolam, ketamine. Those are kind of the most common ones we use. And so the duration, like you mentioned, of how long to administer those therapies is unclear. There's some guidelines that recommend continuing this for 24 to 48 hours, although the data is lacking, admittedly. I think that's problematic because these agents do have a lot of toxicity, and it's important to try to get the agents weaned as soon as possible to prevent additional toxicities, which creates for prolonged ICU stays. And so the paper really looks at how fast we should wean the intravenous anesthetics and what patterns emerge once we do wean the anesthetics. In reality, once you wean intravenous anesthetics, the EEG shows a host of different things. So one, you can get complete resolution of seizures. Two is that the seizures recur. And then three, you get this gray zone, which we termed the Ictal-Interictal continuum. So that's the area in which we don't really know how to interpret these patterns. You can see lateralized periodic discharges. You can see lateralized rhythmic delta. You can see generalized periodic discharges. And when we see these patterns, we don't really know how to interpret them or what they really mean. Some people look at those patterns and then immediately put the intravenous anesthetics back on, thinking that those patterns represent seizure relapse. And so our paper really demonstrates that those patterns may be transition states and that they may not represent seizure relapse. And so we go through a series of cases showing that additional features beyond just the EEG pattern along the interictal spectrum may be more important to guide weaning. So we suggest that despite these patterns, if there's reassuring features, you should really continue weaning, and maybe you'll get seizure resolution.
Can you tell me more about your study design and the patient population?
Sure. So there was a retrospective study that really tracked from May 2012 to July 2017. We really looked at one hospital center. We looked at patients with status epilepticus, of which I think about 118 patients met that criteria. Of those patients, we looked at how many of those underwent burst-suppression. So usually for super-refractory status epilepticus, the patients need to undergo intravenous anesthetic agents, and we usually titrate burst-suppression or seizure suppression. I'm not going to get into the differences between those therapies, but specifically we looked at burst-suppression, and about 22 patients of the 118 met that criteria for burst suppression. We didn't include patients with anoxic brain injury. I think it represents a different population. And so of those patients, 14 were found to be in refractory status epilepticus and didn't really have any evidence of anoxic brain injury. Of that cohort, we looked at patients with super-refractory status epilepticus, which we defined as patients that underwent greater than 24 hours of intravenous anesthetic agents and patients that had multiple weaning attempts, some of which were unsuccessful. All in all, we were able to look at 6 subjects who were in super-refractory status epilepticus, who had multiple weaning of anesthetic agents, and who experienced ictal-interictal patterns when intravenous anesthetics were weaned. There were 3 patients that were not included because those patients did not experience patterns along the ictal-interictal continuum when intravenous therapy was weaned. Those patients just had seizure relapse, and so we didn't really look at those. So again, the focus was to look at patients who had multiple weaning attempts and they had ictal-interictal continuum patterns encountered once intravenous anesthetic therapy was weaned.
In the paper, you looked at the duration of the IV anesthetic therapy, the number of weaning trials, the EEG patterns that you encountered, and weaning strategies. And you define those weaning strategies as aggressive versus non-aggressive. Can you define for our audience what you consider to be an aggressive wean versus a non-aggressive wean?
Sure. So aggressive weaning was defined as patients who had ictal-interictal patterns that were encountered with intravenous anesthetic weaning. And despite ictal-interictal patterns, intravenous anesthetic therapy weaning was continued despite that. Non-aggressive weaning was when intravenous anesthetic therapy was escalated once ictal-interictal patterns were encountered with the weaning.
And I thought it interesting that of the 6 patients that were ultimately identified, that aggressive weaning was the only method used in weaning. Sometimes we will continue to wean, sometimes we will not continue to wean, just because there is no evidence. So I just thought it was interesting that of these 6 patients, all of them experienced aggressive weaning, despite the emergence of these patterns.
That is important to point out. I think it does represent a limitation of the study, certainly an institutional bias that we have, but I think in order to really tease apart our findings, we do need a population of patients that experience non-aggressive weaning when ictal patterns are encountered.
Can you tell us about some of the 6 cases that you encountered?
We do have a variety of different pathologies that represented super-refractory status epilepticus. One patient was a young male who experienced new onset refractory status epilepticus, otherwise termed as NORSE, that didn't really have an underlying cause for that. Another patient was someone that woke up after a surgical procedure and went into status epilepticus without really any cause. Another patient had a previous history of epilepsy in the setting of MS and had some precipitating factor that caused relapse into super-refractory status epilepticus. Another patient was somebody that had leukemia that spread to the brain, and that's what caused escalation to super-refractory status epilepticus. And the last patient was a patient with a previous diagnosis of epilepsy, had a subdural hemorrhage, and that's what was the etiology of the status epilepticus. So we do have a pretty wide variety of cases. I don't think there are any common themes among those 6 cases, but I think the patterns that they encountered with weaning were relatively similar. Now, with weaning, we do describe a multitude of different patterns. Some of those range from LRDA or lateralized rhythmic delta, and some are LPDs or lateralized periodic discharges. And then the weaning trials, the number of them do vary per case. So anywhere from 2 to 8 weaning attempts were performed in our small case series.
Were you able to identify any specific type of Ictal-Interictal EEG pattern that seemed to be more conducive? I know there are only 6 patients, but that seemed to lead to those patients not, I guess, going back into status epilepticus?
We actually didn't, which was surprising because different Ictal-Interictal patterns in the literature have different associations with seizures. For example, LPDs are more along the ictal spectrum of things rather than GPDs, but in our small case series, we didn't find that to be true.
And what do you consider to be the limitations of this? I know it's a small case series.
I think part of it was that depending upon the clinical situation, the clinicians may have been more comfortable aggressively weaning in patients that they felt were less sick overall, and they may have felt more reluctant in patients that were sicker. So I think that represents a limitation just overall in terms of the study. The other ones I mentioned, I think it's important that we do look at a subset of patients that were non-aggressively weaned and see if there was any difference in outcome. In the literature previously, people looked at highly epileptiform bursts and showed that those correlate with weaning failure. That may have been something that we could have looked at that would have helped find which patients do end up doing better with aggressive weaning, but we didn't look at that in our small case series.
I know the etiologies were very different, but did it seem as though the underlying etiology accounted for any effect in determining the overall prognosis and resolution of status?
In our small case series, it actually did not. I know in previous studies, some people think that etiology is the most important determinant in prognosis, and that's something we could have looked into more. But just based on the small number of patients we had, it wasn't clear that one etiology led to a better outcome than others.
So what would you consider to be the take-home message for us as neurointensivists and intensivists treating patients with status epilepticus?
I think the biggest take-home message is that these Ictal-Interictal patterns that we encounter with intravenous anesthetic weaning may not be entirely bad. They may not represent seizure relapse when we see them, and they may represent a transition state. And so if there's other features in the EEG that are reassuring, namely the background, it may be reasonable to forego repeated attempts of intravenous anesthetic escalation and just aggressively wean patients and see what happens. Obviously, further research needs to be done to figure out which of these patterns are more likely to cause relapse than others, but it does show that some of these patterns may not be as dangerous as we previously thought.
Thank you, Dr. Das, for joining us on today's podcast and taking the time to discuss this paper with us.
Absolutely. Thanks, Dr. Shepard, for having me again.
Thanks for listening to the Neurocritical Care Society podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and education in neurocritical care. Our production staff includes Josh Levine, Mike Brogan, Romani Ballou, Sterain Shepard, and Benjamin Miller. Our senior producer is Jim Siegler. Our administrative staff includes Sarah Memon and Becca Stickney. Music by Lee Roussever under Creative Commons license. If you like our show and want to know more about us, check us out on Twitter at Neurocritical, Facebook, or LinkedIn. The NCS podcast is available at NCS On Demand, iTunes, and wherever you may listen to your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.